Hi, this is Dr. Alan Skarbnik. I'm the director of the Lymphoma and CLL program in Adult Health in North Carolina. I'm joined today by Dr. Farrukh Awan, who will introduce himself.
Hi, I'm Farrukh Awan. I'm a professor of medicine at UT Southwestern in Dallas, Texas, and I lead the lymphoma program here. And I'll be talking about our ASH abstract, about the real-world treatment patterns and outcomes in patients with CLL and SLL who have received at least 2 prior lines of therapy, including with a BTK inhibitor and or a BCL2 inhibitor.
Thank you so much, Dr. Awan. Thank you for joining us today for the CLL Society. So could you describe to us what the study was, what your findings and conclusions were?
Yes, so I think all of us realize that there's a huge unmet need in the field, especially after patients fail either a BTK inhibitor or a combination of a BTK inhibitor or BCL2 inhibitors. Those 2 treatments specifically has really improved the outcome of our patients. But what happens when patients start failing that? And we're beginning to see more and more of that. So we basically wanted to focus on and see what are the options for these patients, how are they being treated, especially over the last few years. Are they being referred to clinical trials, or what is the preferred treatment option among prescribers? So that essentially was the goal of the study, was to look at the 3rd line setting and beyond for patients with CLL. So we started off by accessing this really large retrospective database, which is a Flatiron Health database. And we essentially included all the patients who were 18 years of age or older with the diagnosis of CLL. And we divided them into 2 groups. So the first group was the cohort 1 is what we call them, and that had received at least 3 or more prior lines of therapy, and that had to had at least a BTK inhibitor. And then cohort 2 had both BTK and BCL2 inhibitors. Now, these are all 3rd line patients. All of them have had 1 BTK inhibitors and 2 BTK plus BCL2 inhibitors. And then we excluded some patients because of the issues with other cancers which were diagnosed within our study period. So we started off with almost 14,600 patients, and after removing all of those, and a lot of those patients don't get systemic therapy and don't make it to 3rd line for whatever reason. So we are basically left with almost 405 patients who were in the 3rd line setting and had received prior BTK inhibitors. And then in the cohort 2, we had around 57 patients. So the numbers are actually pretty high because very few studies are available in this particular setting, especially for patients who has failed both BTK inhibitors and BCL2 inhibitors. When we look at the breakdown of these patient population, we see that most of these are Caucasians, as expected, and 93% plus, 93 and 94% of these patients specifically were treated in the community setting. So that just shows you that the academic practice in big centers is only a small percentage or small fraction of the CLL practice. The vast majority of these patients are treated in the community setting. All of these patients were around the 71 years of age. That was their median. And that just shows you that this is still relatively a fairly young population, and nowadays 70 is a very functional adult, and they are not, if we had good options, we can treat these guys and they can have a very productive life for a few more years. So it's important that these patients are not considered as too old for treatment because they still have very good performance status for the most part. They're very functional. Another thing that we noticed, which was similar to the trend that we've seen in the past real-world studies, is the fact that a lot of these patients don't get tested for IGHV mutation status or don't get tested for the high-risk TP53 mutations. So more than 60% don't get treated. But the most important take-home message from this particular study was that if you look at the first cohort, which was patients who had failed BTK inhibitors, you saw that a substantial percentage of those patients were retreated with a BTK inhibitor again. So we're looking at almost 40 to 50% of those patients who either had, they had failed a BTK inhibitor, but then got the BTK inhibitor again. This included BTK inhibitor with BCL2 inhibitor, with chemotherapy, with the CD20 antibody, all sorts of combinations. And if you put it together, that almost comes to almost half the patients. So essentially, patients are being retreated with the same drug that they had previously had. Now,
can I ask you a question regarding that? Sorry.
sure.
Why do you think that's the case?
And, that's a great question. I think one was that our study period was only in this last 6 to 7 years. So that's when venetoclax was available. And maybe it was just the lack of knowledge of the availability or the, I guess, the resistance to using it, maybe some apprehension about using venetoclax. And, you can also argue that maybe some of these patients could have switched because of intolerance to one BTK inhibitor to another, but that doesn't explain 50% of the switching within the same class. So I think that was very impressive. And, it's not just that trend for BTK inhibitors. If you look at patients who had failed either BTK or BCL2 inhibitor, only around 20% of those roughly got something else. So 17% or so of them got PI3 kinase inhibitors, and around 14% got chemotherapy. But the vast majority of those patients either went back to a BTK inhibitor or went back to BCL2 inhibitor. So basically, if you're failing a BTK or a BCL2 inhibitor, or if you've had them, then you get retreated. Again, a small argument can be made that maybe those patients had stopped venetoclax because of time-limited duration and then relapsed. But, we've seen that that is not really happening in a lot of those patients. Most of our practices are not that mature that we go 4 or 5 years, the typical remission after venetoclax for most patients, and then need retreatment. That's only a fraction of the patients right now, at least, because the vast majority of those patients do really well. So, this just highlights the fact that there is no referral to clinical trials, or very little referral for clinical trials. The exploration of alternative options is very limited in the vast majority of these patients, and they just get recycled on treatment, which we know is not going to be as effective if you use it the second time around or the third time around. So that was the most impressive message, which highlights that these patients need other options. And the other important thing was, so time to, or the length of time after index therapy, if you retreat them, was really 11 months if you had BTK inhibitor and you start alternative therapy, and it was only 6 months if you fail BTK and BCL2, or if you've had BTK or BCL2 and then restarted another therapy. So that just shows you that these are not kind of the results that we would ordinarily expect in venetoclax treated patients after a BTK inhibitor. So the outcomes for these patients were fairly dismal, and time to next treatments were very, very short. So a lot of things can be done because that's how we can improve overall survival and progression-free survival. And our median overall survival was 33 months for our BTK-treated patients. So that's pretty dismal, 2.5 years. And we know that the median progression-free survival in venetoclax, for example, can be more than that. And then similarly for our BTK and BCL2 treated patients, the median overall survival was only around 16 months. So that just reflects the fact that this is a high significant unmet need for our patients. Not only that, we need to have better options. We need to have exciting newer options which are away from the BTK or BCL2, or maybe the second generation BTK inhibitors would take up some of that space. But I think the most important message was that patients needs to be educated that there might be other options. Maybe CAR-T might be an option for some patients. And then physicians, the treating physicians, need to be aware that these are the patients who might be candidates for alternative therapy, enrollment on a clinical trial, maybe considering the allo transplant in the rare patient who is fit and maybe eligible if we can get their disease under control, and definitely consider them for CAR-T or other such options or bispecifics. So this is kind of the gist of what we did, and it just highlights the need for newer and more effective treatment options for our patients.
Well, thank you so much for the summary here. This is a very important study in my view, because it does depict what is the practice in the community, which, as you said, is where the majority of patients are treated, right? And you know, there are a number of clinical trials ongoing countrywide. Access is always a problem, but also I think the patients being informed that clinical trials may be available actually sometimes closer than they may think, right? And that, you know, the outcomes for retreating or for, you know, after you use both BTK and BCL2 inhibitors, we know, you know, the only commercially available thing would be a PI3 kinase inhibitor, which, you know, the outcomes are not as great and the tolerability, you know, is lower. And those are kind of coming out of availability as well as we move along. So thank you so much for this work. I think it's very illustrative, and I think it's important for the patients who are watching this video in its summary to reach out to organizations such as the CLL Society to understand what may be available to them. So thank you very much. I think it's a tremendously important work. Appreciate your participation today and in helping out the patients in CLL Society. Really appreciative of that. So if you have any other comments to finalize here.
No, I think one message at the end is please ask about a clinical trial, because it's not just the last ditch effort. A lot of these early clinical trials can also significantly improve outcomes with various sort of combination treatments that we have available. But no, thank you for having me.
Thank you so much. We appreciate it.